So without further ado, Dr. Daniel Parker is an assistant professor in public health at UC Irvine. He's also the director of the GREAT program, a student global health initiative within the Department of Population Health and Disease Prevention. His research focuses on spatial epidemiology, especially of infectious diseases, spatial demography, and global health. He earned his BA in anthropology and a certificate in medical anthropology and global health from the University of Washington, Seattle, and a dual PhD in anthropology and demography from Pennsylvania State University. So Dr. Parker, the floor is yours.
Thank you, Meredith. I need to share my screen here. And, okay. So Meredith, are you able to give me a thumbs up if that is working? Can you see? Yes, okay, excellent. Thank you. So you already know who I am. I'm an assistant professor in public health. And what I'm going to talk about today are spatial patterns in COVID-19 cases and testing in Orange County, California. So something that may be of interest to lots of people here, yeah? The way I've organized my talk is I'll start off with a little bit of epidemiological surveillance 101. I will move into some basic COVID-19 epidemiology. Then I'll move into the real meat of this talk with spatial epidemiology of COVID-19 in Orange County. And then I'll finish up with some very preliminary at this time because everything's still new and we're still learning lots of stuff, preliminary conclusions and future directions for this work. So to get this started, let's think a bit about types of surveillance, right? So surveillance is important, it's key for epidemiology, and most surveillance data come from two different types, or two broad overarching types of surveillance. The first type is passive case detection, and the second type is active case detection. Passive case detection is a situation where if you're the data collector, for example, you're sitting at the hospital or the medical clinic, you've got sick people out in the community who come to you and they get diagnosed and tested and they wind up in the data in that way, right? So it's passive because you're sitting there, they come to you. And you can imagine that a lot of people don't make it into the data this way, right? So people who don't feel sick, if they're asymptomatic, they don't show up. Other people may have some kind of a barrier to accessing healthcare. That could be a geographic one, like the hospital's too far away, or it could be that they don't have enough money to pay for services, so they don't go. Or it could be that even after they've gone to the hospital, there's not a diagnostic they can't get diagnosed when they arrive, right? So we think about this as a tip of the iceberg situation. The cases that you get from passive case detection, it's just the tip of the iceberg, and you know there's something underneath the water, but you never know how much. You don't know what the shape of that iceberg is, right? For lots of different reasons. The other type of case detection is active case detection. And this is kind of the reverse situation where you've got a team of medical workers, public health workers, active case screening team. They go out into the community, right? And they start to screen people regardless of whether or not they feel symptoms, right? So this requires a lot of good community engagement so that people participate well. But if you get this done right, then you get an image of what's really going on with that entire iceberg. This can be important for a lot of reasons. Part of which because lots of diseases can be spread even in the absence of strong symptoms. Right? So it's an important thing to know who is sick out in the community, not just who shows up at the clinic. So just keep this in the back of your mind as we talk about COVID-19 and the situation here in Orange County as well. With that, let me take a drink and then we'll move into some basic, or what we think we know about COVID-19 epidemiology. So the culprit that's got us all stuck in our houses these days is shown here in the picture. You can see I haven't had a haircut in a couple of months, so I'm actually starting to look like one of these viruses. This is the causative agent of COVID-19. COVID-19 is an abbreviated form of coronavirus disease 2019. This is a disease that's caused by a new coronavirus that is infecting humans, new to humans anyway, and it's referred to as SARS-CoV-2, from severe acute respiratory syndrome coronavirus 2. It's a mouthful. Likely, this is a zoonosis, meaning that it probably jumped into the human population from a non-human population. And the genetic evidence that we have for this so far is that there's not a lot of genetic diversity. in humans. And that suggests that there's been a recent spillover and that the virus hasn't had enough time to accumulate with the random mutations that they'll accumulate over time. So far it looks like a recent zoonotic event. It jumped from a non-human animal or a non-human animal population into humans. Symptoms of the disease include anything from cough to fever, lung problems, trouble breathing, general malaise, tiredness, also smell and taste problems, lots of different things. The disease was first reported in late 2019 in the city of Wuhan. It's a large city in Hubei province of China, and quickly it reached epidemic proportions there. It spread throughout the world since then into pandemic proportions, right? As of this morning, I just updated these data here, there have been over 3.2 million confirmed cases, over 230 deaths. And this is certainly an undercount of the confirmed cases and almost certainly an undercount of the actual deaths as well. Almost a third of those have been in the United States, where we're over 1 million confirmed cases and over 61,000 deaths from the disease. And then now focusing on Orange County, we've been relatively fortunate. We've got over 2,000 cases and I believe 44 deaths so far. So it's important to keep vigilant. We've been a little bit lucky so far, but if you look at what's happened in other parts of the world, if you look at New York, if you look at the Lombardy region of Italy, if you look at what happened in Iran, we know if we're not vigilant, this can really take off and have a major toll on our communities. So important to stay vigilant with this. It appears that lots of people who get the disease are asymptomatic or mildly symptomatic. Some of those, when they're tested that are asymptomatic, will eventually develop symptoms, but it looks like a large proportion of them never do. For those who have mild cases, usually they will recover within a couple of weeks, but people with more severe cases could take 6 weeks or more to recover. Some people obviously pass away from the disease, and others who do survive will have probably long-term organ damage to the lungs, maybe to the kidneys, maybe to the heart. Lots of things we're still learning about it. So it's a bit of a scary disease. There's also this apparent association between age and disease severity. What this is coming from is that if you look at the reported cases, younger ages really make up a small proportion of the overall reported cases there. Conversely, if you look at severe death and disease, it's most frequently occurring in older age groups. And at the same time, the severe disease and death is quite frequently occurring in people with comorbidities. So it's people with other diseases. And of course, comorbidities and age have an association. You see more of those in older age groups as well. So this can kind of act as a confounding factor. Right? And so keep all of that in mind. We'll move into the real meat of this talk here and start thinking about what's going on in our case, where we're staying here, assuming everybody on the call is in Orange County. So with that, the data that I'm working with today that I'm going to show you, these are the cases and test numbers that are reported to and by the Orange County Healthcare Association for each day and location. And what I've done is I've taken those data and I've aggregated them at the spatially at the city level, and then temporally into weekly groupings. If you look daily, it kind of fluctuates a bit over time, but if you lump them into bigger groups, like a couple of days up to a week, it kind of smooths it out so you can kind of get a better picture of what's going on. And then what I'm doing here is I'm plotting the final 3 weeks of March. Right, so the epidemic in Orange County, it really kind of started mid-March. And so I'm taking the last 3 weeks of March, say March 11th through March 30th, and the first 3 weeks of April. So it's April 1st through April 22nd. And then we can kind of compare what's happened in March and then in April. And that's what I'm going to show here. I'll take a little bit of time to explain this map. So this is for March. It's a map of Orange County. In the middle, I've labeled Irvine. This is where UCI is. And what the map is indicating is the number of reported cases per 100,000 people per week. So it's a reported case intensity. And the lighter colors, so the yellow colors here, those are places with really low case intensity, reported case intensity. And the darker colors, especially the purple and the dark blue, those are places with the high case intensity. And what you can see is the high case intensity places at the beginning of the outbreak are the central coastal areas, right? So if you know your Orange County geography, you know this is Newport Beach, Corona del Mar, Laguna Beach, right? But the situation in April is very different. can see that it has shifted. So some of those places with high case intensity and at the beginning of the epidemic now have low case intensity. And the places with high case intensity now are more in the northern part of Orange County. Right, so these are places like Santa Ana, Anaheim, see Huntington Beach there. So a very different geographic distribution of case intensity, just over a matter of a couple of weeks, really. So what would be leading to this? Well, another important thing to consider with all of this, of course, is testing intensity. So that's what I'm showing here. On the top part of this 4-panel map, these are the same 2 maps that I showed previously. So that's the reported case intensity. But on the bottom, where you can see the red box around it now, I'm showing the testing intensity. So this is the number of tests per 100,000 people per week. Right? The darker green colors are places where there's higher testing intensity, lighter colors where there's lower testing intensity. And what this illustrates, what I'm trying to illustrate with this, is the places where you had high testing intensity at the beginning of the epidemic are overlapping really strongly with the places that had the high case intensity, right? And then as you moved into April, it's much more homogeneous. So testing is kind of spread out to roughly everywhere, but still where you see higher testing intensity is up in that northern area. That's also where we happen to see higher reported case intensity. Right, so this is an interesting pattern. So what does it mean? Well, first I want to caution everybody, this is still quite preliminary. We're still cleaning data, lots of data still pouring in, lots of things we don't know, but we can start to form some hypotheses and general conclusions about these things, I think. So first off, the reported cases were first clustering in affluent communities along the Central Coast. I don't think it's controversial to say Newport Beach, Laguna Beach, Corona del Mar. These are affluent communities. And in fact, I could show you a map, and I will. So this is the case intensity here again. But if you look at a map of median household income, you'll see that those central counties, or those central cities in Orange County, those are places where you have relatively high median household income. Right? And it overlaps pretty well. It's not perfectly predictive, but pretty well overlap with the places where the outbreak really started. Moving on, as the epidemic, the COVID-19 epidemic has kind of progressed in Orange County, testing has expanded, and we're now seeing more cases up in the north and more higher population density areas. So this is the map for April. You can see up in the northern areas there, that's where the higher case intensity is. And again, if I showed you a map of population density, so this is the number of people per square mile, you'll see that it overlaps relatively well with where the higher case incidence is now. Right. So what can we take from this? People, I've got a couple of hypotheses, they're not mutually exclusive. So people from high incidence communities at the beginning of the epidemic, I think it's possible that they had stronger ties to other communities in other parts of the world. Right? So perhaps people that are living in those communities where the epidemic really started off were more likely to have traveled internationally and could have been at risk of acquiring infections earlier because of that. Right? There were many epidemics occurring in many other places at that time. Another possibility, though, is if you remember, it was quite difficult to find tests. There was a shortage of tests at the beginning of the epidemic. Even here, we knew it was coming, but there was a shortage, and so it's possible that people in those more affluent communities had better access to testing than other people did. This changed quickly. Of course, it spread out homogenously in a matter of weeks, but it's possible, I think, that, and both of these things could be true. It could be that they had higher risk and had quicker access to testing. But taking these things together, I just want to point out that socioeconomic status has a major impact on many attributes of epidemiology, and that's not just relevant for COVID-19 in Orange County in 2020. This is a major thing for any disease, probably everywhere in the world, probably for all of time, right? And it doesn't just have to do with risk of infection and access to healthcare and testing. It also has to do with social distancing. Right, so now, as we've moved on, I think if you are independently wealthy, if you're working jobs where it's easier to work from home, if you're like me, a researcher, an academic, it's not very comfortable, it's not pleasant, but my work can continue at home, right? But for many people in our communities and in our county, that's not an easy possibility. So for some people, if they're staying home, they're not getting a paycheck, and eventually that's going to mean it's going to be difficult for them to put food on the table. Or the other option is that they continue to work, coming into contact with lots of people, coming into contact with objects that lots of people have touched. And I think it's been an eye-opener, interesting to watch across the country and across the world, really, to see as everything is shutting down, as we have this social distancing mandates being put in place, what we consider to be essential work, right? And it's not just our first responders, our medics, and our policemen and things like that. It's also people who cook food for us and provide food for us and sell us food, right? It's people who are working at grocery stores. And I think this is fascinating to think about, but many of these people, they work in precarious conditions, maybe don't have the best access to healthcare, and maybe are at higher risk of infection now. I think we really need to come to grips with that now, and hopefully some changes will come from this. So I'll finish by pointing out that coming around full circle. So we've got passive case detection here, right? That's what these data are coming from. They are people who have felt sick, they made their way to a medical center and were able to get diagnosed and tested, and that's how we know that they had the infection. But really, we don't have any idea of what's going on underneath the water with this iceberg. It's just the tip of the iceberg. It could be very small under the water, it could be enormous. We have no idea. And so, in order to get at that, what you really need is to go out into the community and start screening people. And I think you're going to see some exciting movement in this direction in the upcoming weeks and months. But I'll leave that at that. I'll leave that door open for further talks. And so I want to give out some thanks. There's tons of people at UCI that are working on COVID-19. I didn't list all of them here. I tried to keep this just to the data that are underlying these maps. So I'd point out that Dean Bernadette, we've got these long-going collaborations with Orange County Healthcare Association, but Dean Bernadette has really been a catalyst for these collaborations. So she deserves thanks for that. Professor Tim Bruckner provided some of the census data so I could map out median household income and population density. And then of course our collaborators at the Orange County Healthcare Association, including Matt Zahn, Nicole Quitt, Alyssa Drake, Richard Travers. And for that, say thank you. I hope I haven't put you guys to sleep. And if you have questions,